Next, you will hear from Dr. Kabani.
Good morning, everyone. Thank you so much for being here today and taking time out of your busy schedules to spend 3 days with us. And thank you for the NHSN team for inviting me. I'm an adult infectious disease physician, and I work in the Office of Antibiotic Stewardship in the Division of Healthcare Quality Promotion, but work closely with Dr. Thompson and Dr. Bell on all issues related to antibiotic use and stewardship and long-term care. So what I'm going to be doing today is expand on some of the concept that Dr. Thompson just talked about right now in terms of antibiotic stewardship and implementation in your facility. So by the end of this sessions, what I'm going to do is discuss ways to track the core elements of antibiotic stewardship, but the framework that I'm going to use is the facility survey that you fill on a yearly basis, where there are questions that are pertinent to antibiotic stewardship at your facilities, and identify some opportunities to improve antibiotic use in UTI, specifically using the UTI module, and how to monitor outcomes using the LabID event reporting. So the work that Dr. Thompson just presented on looking at antibiotic use in a prevalence survey is antibiotic use on one specific day in nursing homes. And our office has been doing some work working with partners, whether electronic health record companies or long-term care pharmacies, where we look at antibiotic use sort of cumulatively overall throughout the entire year. So numbers we used to quote in the past, as Dr. Thompson had said, were based on very few studies, or we used to look at European data and try to extrapolate some to the US. But we are learning more and more through the work that Dr. Thompson's and her team are doing and the work that we are doing. And this work is still preliminary, but we've recently presented this at a conference. We know that there's an estimated overall of 50 nursing home residents over the year 2017 that were prescribed one or more courses of antibiotic in a year. And facilities range where you have 44% at a facility over the entire year to 58%. And there's a lot of variables that come into play, such as whether these residents were short stay or long stay residents, and we will be sharing more and more data on this as we come along. So we're learning and defining more overall antibiotic use, but we know from previous data that an estimated 40 to 75% of those antibiotics are inappropriate. Of course, there is a proportion of that is unnecessary to begin with. But when we talk about inappropriate, we're also talking about the drug selection. And Dr. Thompson talked to you about fluoroquinolones and whether they're the best drug for a specific infection, whether the dosing was appropriate. And we know from many studies that we frequently treat nursing home residents for longer than they actually need for a specific infection. So why are we talking about this? And I know you all have heard this multiple times before, but we're now becoming to appreciate the adverse events that are associated with antibiotics, both necessary and unnecessary use more and more. Adverse events such as gastrointestinal disturbances and yeast infections, to very serious adverse events that we're learning more about, like the neurotoxicity that's associated with fluoroquinolones, especially in the elderly population. And unique to the nursing home setting is the multiple drugs that these residents are on and the increased risk of adverse events with drug interactions. And just one small study into nursing homes, we're able to assign 13% of adverse events to antibiotic use. You've been talking throughout the past few days about Clostridioides difficile infection, and one of the main reasons is antibiotic use and microbiome disruption. And the resident population you take care of are not only that is highest risk for C. diff infection, but they also have the highest morbidity associated with it and the highest mortality. Out of a study in Canada, when they looked at diarrhea, gastroenteritis, and C. diff infection, that was the most common antibiotic-related adverse event that was seen. And we are having more and more evidence now that there are higher rates of sepsis in people who have used antibiotics. And this is still very preliminary data, and you can't assign causation. But there has been some theories that this could be secondary to microbiome disruption and risk of infection. So, as I say, we continue to learn more and more about these drugs and what they can cause in the vulnerable patient population you take care of. I know all of you have seen the definition of stewardship before, and we've been talking about this. This is new to the nursing home community, but we've been talking about it for a few years, and I didn't think I needed to define what stewardship was anymore. But just a few months ago, we were doing a special session in the American Medical Directors Association meeting earlier this year, and we asked the community of providers who were there, who were very interested in stewardship and who have been doing this for a while, what do you think? What is antibiotic stewardship? And the universal answer we get was to decrease antibiotic use. And so I feel we need to talk about this again. Antibiotic stewardship, decreasing antibiotic use is a very small proportion of it. It is by definition the sets of commitment and action to optimize the treatment and infection and reducing adverse events. It's an issue of safety and delivering high quality healthcare. Measuring antibiotic use is stewardship. And we call it optimizing use. A proportion of that is not giving them when they're not needed, but as we mentioned, it's giving the right drug at the right dose for the right duration is what antibiotic stewardship is all about. So, Dr. Tan, you all have seen this before, and Dr. Thompson told you about the core elements of antibiotic stewardship that provide the framework for how do you assess current activities and how to identify new stewardship activities. And so I'm going to be going over the questions and the yearly facility survey that you fill to discuss these different core elements. So the first one is leadership commitment, and you have two questions in the facility survey on how to identify leadership commitment at your facility. And we know that without nursing home leadership commitment, you cannot implement antibiotic stewardship. You need that support and that commitment, whether it's moral support or the financial support or the training support that comes along with it. And the data that Dr. Thompson showed you, that this wasn't one, it was around 60%. And it's the first step is that commitment, and it can be through written statements that support improving antibiotic use that you share, that the leadership shares with staff, with residents and their families. And here's an example of a letter that the leadership can adapt to use at their facility that spells out some of the broad overview of what they're going to do. And reviewing antibiotic use and resistance data and the quality improvement meetings can also be a way of demonstrating leadership commitment. So the second core element we'll talk about, and the question that addresses is here is at the bottom of the page, is identifying those individuals who will lead stewardship implementation. If there's no specific person is responsible, no one is really responsible. And different people can support stewardship in different ways. And I'm going to talk a little bit about the role of the medical director, because there's a lot of different ways your medical director can support stewardship, even if they're not doing this hands-on on a day-to-day basis. First is just role modeling. If they are using stewardship principles in the way they evaluate residents, treat them, that alone is very, very helpful. They can help with policy development, with providing education, not only to your staff, but also to your residents and your family. And they do have a critical role that not many other people can play, is providing some of that feedback when we talk about reporting to providers on their prescribing practices. It's a difficult position for a director of nursing or an IP to be put in that position, to call different prescribers and tell them about this. And the medical director plays a critical role in providing support in that process and in that follow-up. And, the director of nursing, of course, has a role to play in providing of education and implementing of practices. I will talk a little bit about the consultant pharmacist later, but also the IPC coordinator. She have key expertise and data to improve antibiotic use, but requires some training, some dedicated time, and the resources to help implement stewardship activities properly. So we'll move on now to drug expertise and establishing access to individuals with antibiotic expertise. And more, and I know there's a lot of variability around the country, and we hear that anecdotally from many of our partners about the extent that long-term care and consultant pharmacists play in supporting stewardship activities, but there's several ways that can be done. They can help you review your antibiotic use data, or even support tracking of antibiotic use, because they have access to a lot of the prescribing data, and they do this in their own in their own role as they review medications. Dr. Thompson talked to you about the documentation of prescribing elements. So when pharmacists review orders, they can ensure that documentation of prescribing elements. And it is one of, in the interpretive guidance of the CMS requirements, documenting a dose indication and duration for every single dose, for every single antibiotic prescribed is in there. So pharmacists, when those elements of documentation are missing, calling providers and asking them about this, it's part of their, it's going to be part of their job to make sure these data elements are documented. I know it's tricky because in the long-term care setting, pharmacists play a different role than, for example, in the hospital setting. In the hospital setting, you have your pharmacist there. She's seeing the order as soon as it's placed. She can adjust it, adjust the dose. He or she can adjust it, adjust the dose, call the provider back. And whereas in the long-term care setting, especially your consultant pharmacist, their role is somewhat more, sometimes in review or in retrospect. But that said, they can help in limiting antibiotic duration. For example, if they're looking at the prescribing of UTI over a course of a month, and let's say most of the residents ended up getting 10 days for a UTI, which we know, especially for uncomplicated urinary tract infections, that's too long. They can provide feedback to the providers, and we're seeing these practices, and you should consider ABC and look back at our protocols and see how we can do better. So other than duration, they can also help with improving prescribing practices, as we said, in protocol development, and providing education for staff, as they have that expertise that many of your frontline staff needed. In ASB treatment, so when they are doing that review, if there's no documentation of signs and symptoms, and this UTI event looks like more asymptomatic bacteriuria, providing that feedback can help. It's not going to help that resident there and then, but it's going to help as we move along down the line to prevent those inappropriate practices. Dr. Thompson mentioned the use of prophylaxis in this setting. So even identifying those residents who are on prophylactic use and having a conversation with the prescriber, do you think this is necessary? How long do you think we should continue? Do we think this really helps? As the evidence for this practice is not very, very strong, and there is a lot of concerns of adverse events with prolonged use of antibiotics. And fluoroquinolone specifically, and this is becoming more and more priority in this setting, as it was the most commonly prescribed antibiotics. Discussing what are alternatives, making sure the emergency box on your floor has alternatives. Nitrofurantoin is in there, and there are alternatives to fluoroquinolones on the floor that you can use as an emergency. So that you can avoid the use of those agents. Many facilities are looking into developing partnerships with antibiotic stewardship leads and referring hospitals, and there's a lot of work you're doing right now on preventing readmissions, and so you can leverage those partnerships as you work with hospitals for educational resources for your staff and expertise, and making sure the communication across transitions includes antibiotic information on antibiotic use. So we'll move on now to actions. And there's several questions in your facility survey that reviews the actions on policies and practices that aim on improving antibiotic use. And I will discuss a few of them. So we talked about improving the documentation of indication, dose, and duration. There's a lot of effort going on around that right now, with pharmacists trying to get all that information, with some electronic health record companies mandating that you enter an indication for every antibiotic order, and making sure there's adherence to this documentation policy. The development of this specific facility-specific treatment guidance for common infections can be helpful. For as you provide feedback to prescribers, for UTI, our first-line agent is it's nitrofurantoin, it's Bactrim, it's not ciprofloxacin anymore. Having those documents to support you, having those documents developed along with those different prescribers, disseminated, use them to provide education, can help you not only in tracking those practices but providing feedback on them. You talked a little bit about providing the antibiotic timeout or that antibiotic review. It does have some challenges, as Dr. Thompson was saying, in working those in building those into the workflows, as you don't have this prescriber on site except for once a week, for that identifying that designated person who's going to go see Mr. X was provided that drug, and this is the plan for it. How are they doing? How are they responding? Do we really think they have an infection? Should we continue this or not? How long are we going to continue this? Is there a culture we need to check? Building into the work process that designated person who is there, who can review all those data elements and do this has been a little bit tricky. Some pharmacists have access to that information, but not all of them have the culture data. Sometimes the IP or the director of nursing have access to that information, but may not, frequently don't have the time and energy to dedicate to this activity on a regular basis. And doing it, only once a week or only once to every 2 weeks is not going to be very effective to provide resident care. So we are doing a lot of thinking and discussion on how best to integrate this practice into the nursing home setting. I'll move on now into tracking and reporting of process measures and measures of antibiotic use. And there are several questions that address and there are a few questions in your facility survey that can address multiple core elements. So, if you go back and look at these slides later, you're going to see some questions are mentioned under several core elements, because sometimes one question can address one and a sub-question can address another. So tracking of antibiotic use can help guide practice changes. Frequently when people come and ask us, I want to do stewardship and I don't know where to start and what's the best way for me to approach this. And the common answer we give back is you start from your own data. You need to look at your own prescribing practices. What are you prescribing antibiotics for? And this is where you identify opportunities for improvement. Do you have a large subset of your residents who are taking prophylaxis for prolonged periods of time? And those can be, that can be improved. Is UTI the primary driver in your facility? And you need to address, improve testing and treatment practices for that. Is there a lot of empiric testing on admission that some facilities still engage in that drives prescribing? And maybe we need policies around that. Are we doing a lot of tests of cure? Let's say we treat someone with C. diff and then test them again at the end of therapy and end up giving more and more for not a real infection. So looking at your own practices, what you're prescribing and what you're doing is, it's not an easy answer, but it's where a lot of the facilities need to start. And I know there's a lot of challenges in data sources in this setting, but many facilities are looking at getting their antibiotic use data from different sources. So long-term care pharmacies, some of them now provide dashboards that can give you antibiotic use reports that provide you an overview that can be reviewed, that can help. They dispense and deliver medications. They provide drug regimen reviews. And so some of them can provide those reports, and some long-term care pharmacists can help you interpret them and know what to do with this data. We know that EHR implementation is very variable across the country. Whether facilities have an electronic health record system, what they're using it for, whether they're using it to order drugs or not. There's a lot of variability over that. But we know the uptake is increasing slowly. And, we're not at the level where hospitals are, where you have an EHR record in every hospital, but things are moving slowly into that direction. So some EHR systems can provide you with antibiotic use reports for your residents. But in many places, similar to what facilities use to collect infection data with their infection log, the only way they can collect antibiotic use data is by keeping a log. And that, if that's the only way to do it, that's the only way to do it. And, not ideal, it's labor intensive, but it can provide you with information on what you need to do. So in terms of looking at antibiotic use measures, there's many nursing home programs that track new antibiotic starts as part of their infection surveillance activity. On a day-to-day basis, that can help you with, identifying the subset of your residents on what antibiotics there are and what the indication is. And more, the antibiotic use reports that you're getting are based on antibiotic days of therapy. And this is what's being used in hospitals to track antibiotic use, where you identify different residents, what drugs they're on, how many days where they are on antibiotics, and those are added and to provide a measure over time of what you're using. This may be more accurate when using EHR systems or pharmacy, and this form of tracking is more useful when you're looking sort of at the big picture, when you're in your QuACP meetings where you're looking at your quarterly use and your yearly use, and you're comparing different time periods to see what happens. So, tracking antibiotic use on a day-to-day basis looks a little bit different than what you're doing when you're reviewing, quarterly or yearly. Dr. Thompson talked to you about urinary tract infections, and this is commonly an opportunity for improvement because we know asymptomatic bacteria is sorry, I moved on to another slide. Yeah, so another way to look at antibiotic use rates is looking at it by class, to look at your fluoroquinolone use, specific resident type. Your short stay population and your long stay population have different needs and different requirements. Documenting indication when it's available, it's helpful. And sometimes the location within the nursing home and the unit can be helpful. And prescribers to identify those negative deviants or those individuals who you need to sort of follow up more closely with or keep a closer eye on sometimes can help. There are challenges in that, and we recognize that, but getting this data over time can help. And providing that feedback is helpful. There is a subset of prescribers that no matter what you do, it's just they have a specific way of doing this, and they may not respond. But overall, and we've been doing this for a while, people want to do the right thing. Nobody wakes up in the morning and says, today I'm going to give a resident an antibiotic that they don't need. They're doing this because of a lot of limitations and difficulties and challenges, and facilitating stewardship implementation and facilitating a review and giving them feedback and tools so they make sure that the residents are safe and they're being followed up appropriately is what's needed. Now I'll move on to urinary tract infections. So, asymptomatic bacteria is common in this population, and there's studies that have shown that in your nursing home residents, 15 to 35% of asymptomatic men, you check their urine, they have bacteria in the urine. 25 to 50% of women, and everybody on a catheter has bacteria in the urine. So that over-testing and testing that culture without, a good index of suspicion for a urinary tract infection leads to unnecessary treatment, risk of adverse drugs events, and delays in diagnosis, as a lot of times that testing is triggered by a changing condition. So, we have a lot of anecdotal cases, and I think every one of you have seen a case where they were treated for UTI and they turned out they had, a TIA or a stroke or something, or an adverse event from a different drug or something else, or dehydration or something else completely going on. We know from some data that up to half of the antibiotics prescribed to treat UTI in older adults is either unnecessary or inappropriate, such as you give them quinolone as a first-line agent. So and you talked about the use of the urinary tract infection module, and I just want to highlight how the use of this module can help you track some of your practices around testing of UTI, about antibiotic tracts that you provide, and about those UTI events that help meet surveillance definitions. And this can help you track the testing and treatment practices at your facility. And you can look at your antibiotic use through the antibiotic starts for that specific infections. As we said, the CMS regulatory guidelines, tell you need a system to track antibiotic use at your facility. And, but they don't really specify where that data is coming from, what the focus of it is. You need to have a system where you're collecting data, where you're looking at this data, and where you're acting in this data. You've seen those slides before, but I'm just bringing this in. You can look at a line list and a rate table from that module to look at your practices. And the line list shows you all those different UTI events that meet surveillance definitions. And you also have all the events that you're treating, regardless whether they meet definitions or not. And that helps you calculate a total rate for your facility. So other than monitoring what we call a process measure, which is antibiotic use, which is where you need to start when you implement stewardship, also monitoring health outcomes can help you guide practice change. We talked a little bit about antibiotic susceptibility profile and microbiomes and some of the challenges that you have in getting that data. antibiograms can be helpful in many different ways. When an antibiogram data is available to your facility, it can, just by showing your prescribers the rates of resistance that you have, for example, for E. coli in UTI, and from data we've looked at, universally those rates of resistance for quinolones are high. Just by telling them, what we've tested, 70, 80, or whatever number of samples are resistant to quinolones, we shouldn't be prescribing that as first line for UTI, can help you with improving practice. It can help inform your guidance for treatment of UTI and identifying your first line agents for treatment. But that said, we frequently hear from some nursing homes, it's, I have a small facility, or my lab cannot get me an antibiogram, so I'm sorry, but we can't do stewardship here. And there's a lot of other ways, antibiograms are important. They can help you, they can help you with practice. But we also know that, not many people know what to do with it. I've also heard anecdotally from a DO, and she said, I spent 9 months to get an antibiogram for my nursing home, and I was on the phone every other day, and I talked and sent letters and emails, and then finally I got it, and I got this paper, and I don't know what to do with it, and I put it in a file, and it's on my shelf. So, getting that data is helpful, and it can guide practice change, but there's a lot of other things you can do to improve practices. And another thing to track is, what you're doing through the CDI module, is the rates of C. difficile infection at your facility. I want to emphasize that although improving use is a priority, improving infection control practices and vaccination rates can prevent those infections, and you wouldn't need an antibiotic to begin with. And a lot of the conversations and what we've been talking about the past few days in terms of surveillance of infections all feed into, you want to prevent these infections to occur from the in the first place. And all of you struggle with a lot of limiting resources. And we've been having a lot of different conversations with partners. How can we integrate quality improvement practices together? How can we make sure that stewardship practices and infection prevention, which stewardship and the regulatory guidelines fall under, and early sepsis detection, and how all of these things fit together, so you're not doing, different quality improvement initiatives, but all these principles are working together to improve resident care. And we know education alone is not enough, but education is where you need to start. And we know that your frontline nursing staff are critical in building a team that are working to improve communication and implement any quality improvement initiatives. Many times we hear, we talk to the providers, we implement a practice change, but then, someone on the staff walks in and tells the resident, oh, that urine smells nasty, I think you have a urinary tract infection. So making sure that everybody is on the same page and everybody, is part of this process is critical. And education to residents and families is part of the core elements. And it's important to set those expectations early. And this is not a conversation you have with a resident and family when mom is confused. This is a conversation that should be had, on admission, on an ongoing basis, through a resident council meeting, through letters and education that's provided. And part of it is for us to say, we've been doing this wrong for a while. Residents and families didn't learn about UTI and antibiotics from TV or from an ad. They learned about it from us, and we've been doing this, telling, anytime something happens, oh, this is probably UTI, and Cipro will clear it right back up. And, and it's okay to say, we now know more, and we know many adverse events that we didn't appreciate it before. And just in case is not good enough anymore. We need to keep a closer eye on this and do the right thing for your family. So having those conversations early and having, and of course, personalizing it to every specific situation. These are meant to be guidance, and this is not meant to tell you, what to do in your clinical practice when you take care of your own residents. At the end of the day, you're there, you're seeing them, and you know best. I want to talk a little bit about effective communication with residents and families. And a lot of the work that our office does is exploring and looking at different ways to improve antibiotic use. And we know that a lot of the antibiotic use is a behavioral, it's a behavioral issue. Not every single antibiotic prescribing decision is a thoughtful decision that you make. A lot of it has been built over time with practices and has an impulsive component to it. And changing behavior is not very easy. So And look, we've been looking at ways to improve communication between providers and their patients, to improve the uptake of those treatment recommendations and make sure they are satisfied. A lot of us, and I know from myself, I don't want to take care of a patient and have them leave unhappy with the care that I provided for them. You want them to trust you. You want them to feel confident in the care that you provided. So, with all the caveats of patient satisfaction survey, which is a whole other discussion I can talk about for a full hour, we are human beings, and we want that positive reassurance that, they're confident in us and they're happy with our care. So how can we deliver that information and that necessary care, and which is sometimes not giving an antibiotic when they want it, in an effective way? And a lot of this work has been done in outpatient clinics. So, extrapolating it to other nursing home residents is really, really tricky, and it's something we're exploring right now and working on. But I want to review with you effective ways of communication that were found to work in the outpatient setting. And they were found in multiple studies to improve antibiotic prescribing. And they were found to be a very low cost, sustainable intervention that when you train providers on effective communication skills, it's not only it works, but it also, a lot of the interventions we do, such as education and EHR modules, they work for a while the intervention is there, but when you stop looking, people usually revert back to practice. Communication was one of the few interventions that were improving communication is the few interventions that were found to be sustainable. So those principles are, and they review them in that specific way, start with, making a case for diagnosis. And many of you have been doing this for a while, and Integrate already do this in some of the ways when you talk to residents, but, having that formal way, especially for newer providers, can be helpful. So making the case for your diagnosis, like, reviewing your findings. So for example, Mrs. Jones may be sleepier than usual today, but she does not have a fever. She does not report burning on urination, urgency, or any other symptoms that suggest she has a urinary tract infection. Although her urine does seem darker, but it seems like dehydration and not really a UTI. And then you move on to explain why an antibiotic is not needed, and you combine it with sorry, this is written wrong. It's combined with a negative recommendation followed by a positive one. So you need to start with, I don't think she needs an antibiotic. And I think it's going to cause her more side effects like diarrhea rather than help her. And then follow with a positive recommendation. Instead, we will initiate a hydration protocol with IV fluids to try to address her dehydration. And it's very important at the end that you give people a contingency plan, that if I'm doing doesn't work, what's going to happen at the end? So, we will continue to monitor her. And if she does not improve, we will reassess her, do cultures if they're necessary, and start therapy if she has a fever or if there's any signs of infections. And as I said, these principles have been tested in the outpatient setting. And I'm curious to hear your thoughts, whether training people around trying to improve their communication could help. And we've been talking a little bit about education and improving communication, and there's several training resources that are available to you and your staff, and you've heard about them before. I'm going to focus on the stewardship component in them. So CDC has a training on antibiotic stewardship that includes a module on the treatment of urinary tract infections, and although that is meant for the outpatient setting, a lot of the principles in it on asymptomatic bacteriuria apply to the nursing home settings, and we were very mindful when we were developing it to focus on older adults in it. And there's another one that is focused on stewardship in nursing homes. This module is a good module to provide an overview of, what is stewardship, why is it important. It goes over stewardship into different settings and some specific infections like respiratory tract infections and urinary tract infections. And all of those are available with free CE credit online. And I know you've heard about the infection prevention and control training course that was developed in collaboration with CMS, and there is a module in that also on antibiotic stewardship. So Dr. Thompson reviewed with you from their own prevalence survey work what they've seen in terms of implementation for nursing homes for stewardship. So the data you report to us, we learn a lot from it, not only the infection and the surveillance, but also the facility survey you fill on a yearly basis. And all those questions I've been going over with you right now, we look at the data and we analyze it and see, what's happening out there and what our facilities doing. So we looked at 2016 annual survey data and facilities that reported their stewardship practices, and we we found that there were 42% of facilities reported implementing all 7 core elements. And as Dr. Thompson was saying, this is, this is reported data. So what you say, yes, I have leadership commitment, can be very, very different from when you say I have leadership. And some of it may be true and some of it may be not. That said, the way we look at this data is we look at the gaps. So when someone says, no, I don't have it, we know for a fact that they don't have it. And figuring out where nursing homes are struggling most and trying to provide resources and work with partners to help implementing that core element specifically is helpful to us. And also for us to track that implementation over time and see, where people are doing better. For example, leadership are identifying it's a priority within CMS regulations and writing commitment letters and reviewing data, whereas reporting remains to be a challenge for everybody. It helps us also figure out what we need to do and how we can support stewardship implementation. And so we found that that both reporting and education are big areas where facilities struggled with most. So in summary, we defined antibiotic stewardship and talked about specific actions that can help you optimize the treatment of infections. We went over the annual facility survey, and also when you fill this data, you can identify opportunities where to implement the core elements. So when you say no to a specific question, this is something you can look into. It's like the checklist that's under the core elements that lets you look at every core elements and identify what you can do. Looking at that facility survey every year is also an opportunity for improvement. And looking at the urinary tract infection modules to test your testing and treatment practices for UTIs can help you also improve antibiotic use. I'd like just to make a quick plug for US Antibiotic Awareness Week in November. This is, our yearly, a weekly event that we do every year around November, where there's a lot of social media activity and educational activities around the improvement and antibiotic stewardship and improving antibiotic use across the spectrum of healthcare. And many times there's very specific nursing home materials that are released at the time, or interviews and studies and educational content that we post at that time. So mark your calendars. Many state health departments where you are participate actively in that. So you may be hearing and getting email, and participation is welcome. So this is all I have. Any questions can be addressed to antibioticuse@cdc.gov, and maybe with the version that we share with you, I'll also add my email to that. So if you have any questions, you can refer to me, and I'm happy to take any questions now.
So I have 2 comments. One, I'm very excited to hear about you addressing patient-family education. I'm glad to hear about the patient-family education. As I travel around the country at our medical director meetings, what I consistently hear over and over from our medical directors and providers is the family and patient pressure that they'll go in, they'll have those discussions about why they don't feel it's needed, but you have the family member who's well-intentioned that says, my mom, when she has a UTI, she's always this way, and if you don't give her an antibiotic and something happens, it almost becomes threatening.
Yep.
And they after the while, they say, Linda, we give up. We bang our heads against the wall, and sooner or later we just give up, even though we know it's not best practice. Mm-hmm. So I'm glad to hear about that education. And then the second is, when I'm at these meetings educating them on stewardship, it would be great if I could have written from a physician perspective, a 1-page with some really key, written in their language, bullets that might be able to drive things home better for their education. We talked a lot about the things that you mentioned on your slides, but I don't know if I'm not using the right language or whatever, and maybe if I've written in physician language, it might be better, but maybe that might also be helpful for centers when they're working in educating their providers, some key points from a physician perspective on what to say.
Yeah. So you're saying sort of a script to communicate with providers better. We can certainly talk about that and think about that. And part of it is like we were talking. Education is not a it's not a one-time thing you do once and check the box and move on. Changing practices that you've been doing for years and beliefs that your residents and families have, it takes time, and it's an ongoing conversation, and you start and you go on. But the lot of the educational content I refer to is meant for clinicians, and highlights those practices and issues of adverse events with those. So doing those modules that are that are free, that are available for CE credit very easily, and you don't have to do the full thing. You can pick and choose. There's several modules, and you can pick and choose each one you want. And so sometimes prepping some of the talks, and we found that to be effective when we give talks and webinars. We prepare for it with one of those modules that we send people to do ahead of time, so we're not going and starting that conversation from scratch. And that's been we've received feedback that could be helpful, where you sort of plant the seed and highlight those principles before, and then you start building on them and having a conversation.
To just one point, I appreciate what the woman that just spoke said. And I appreciate what you said about kind of following the negative by a positive. There was some work done. I watched some webinars on work in this area with parents with children in pediatric settings also. But also your point that it's not about necessarily taking away the antibiotics, but looking at the right, drug, the right dose for the right amount of time. So if we could really promote that message, because I know even as a healthcare professional for many years, when I first heard about antibiotic stewardship, that was kind of my first thought too. Like, oh, we just don't care about people. We're just going to let them die. It's kind of, that's kind of what I heard and what, was kind of in the back of my mind too. And especially with the elderly, do we really care about those that are aging? Maybe we're just thinking, well, what are they really worth? We'll just, not take care of them well. And so I think there's some really huge issues, especially in nursing homes, with trust. And, many people, if you talk to them, will not want to go to a nursing home. Most people I know do not want to end up in a nursing home. So I think we really need to think about that.
Yeah.
And so when you're coming, when you're caring for someone and you have an excellent relationship with them and they trust you, and what are you offering them? What are your protocols within your facility? Like if I'm laying there and you're telling me you're not going to give me an antibiotic, but I'm having these discomfort, what are you offering me?
Exactly. And that's what I meant but when I emphasize when you're talking, it's not only for communication, but having it in practice, having that contingency plan that, there is a complaint, that there is a change in condition that prompted that thought, is this infection? Do I need to treat it? And what we are saying in your complicated patients, this is not always an infection. And sometimes antibiotic give you that false sense of security and you're missing what's actually going on. So knowing what's, having a contingency plan, having an active monitoring protocol in place where I'm going to recheck you in a couple of hours for the next 24 hours to see what's going on. I'm going to evaluate you for other causes. I'm going to give you some fluids and having that conversation. And I want to emphasize again what you said. There is that distrust, and we're moving, especially in the elderly population, emphasizing safety and emphasizing that this is not about taking an antibiotic away, it's about giving it properly. And that also is, I don't know if you've seen, it's changed the communication that we do about stewardship in general. Early in the days of stewardship, all we did was talk about resistance at the population level. And I know from my own practice, when I'm sitting there talking to a patient, and I'm worried whether they have an infection or not, and they're going, and who's going to check on them, and whether they're going to die from sepsis at home because I missed something. I really don't care about resistance at a population level. I care about the person right there in front of me. So the emphasis of talking about stewardship in terms of resident care, in terms of giving them the right drug, and even when we talk about resistance, it's a resistant infection that you're going to get in the future, not that somebody is going to get, maybe in another hospital, or we talk about resistance in nursing homes as a threat to other places, but it's not. It's resistance as a threat to the residents that we take care of. So making it individual, making it about the resident, about their safety, about the risk of resistant infections in them in the future is how we communicate around this. And we all have been very mindful of this, and it's been directing our policies, our communication material. So it's about, making it a safety issue, not taking, stewards are told like we're the antibiotic police and we're taking your antibiotics away. I don't want that title, and I don't think anyone else does.
Um, just one word. I just wanted to share just a couple things I wanted to share. I'm from Fairfield, California, and I just wanted to say that our building or our area is very fortunate, and I appreciate the HSAG, because they did in the past, they did have a series of training or webinar about antibiotic stewardship. And so my administrator and my director of nurses, they're very supportive on this. So in my facility, we do have a quarterly meeting. My administrator hired infection MD from the acute hospital, and we meet with the infection MD and the doctors, providers in our nursing home. And then on this antibiotic stewardship, I have expressed to the doctor that if the nurses has spoken to you, let's wait for the 3 days when the culture comes back, and we're going to monitor the patients, and we're going to provide fluids and everything before we start an antibiotic. Please don't get offended. So that alone can improve the communication with, or the rapport between the doctor and the nurses. But then, when you said about the communication, and that is very important, but I wanted to add too that documentation comes along with
Yes.
it, because you know why? We just had a survey last month. You think we did good? No. And this is the first time, because I'm on Northern California, this is the first time we had a surveyor from Southern California, from Orange County, because there's not enough CMS surveyors, so they sent these folks to our building. And this is the first, every year I get interviewed by infection prevention, on the infection control, and we always do good. But this year, this lady, she has the McCreer guidelines in front of her, and she will go through by, the symptoms, and she asked me to look on the record, show me these symptoms. And if the symptoms is not in there, she asked me, now, can you show me the documentation that the nurses attempted to call the doctor and documented that, look, doctor, there's no symptoms, the culture is negative, can we stop the antibiotic? And unfortunately, there was no documentations. That's why I want to say they go hand in hand. So, and we're all long-term care facility, and I don't want that. I don't want you to be on that position like what happened to me, and I just felt like, I don't know what to say. So I just wanted to share that.
No, thank you so much. And I want to emphasize, monitoring whether you give antibiotic or you don't give an antibiotic. In either way, it's critical. And as you said, in documentation, for surveyors, for litigation purposes, whatever you end up doing, it's really important. I don't know with time.
Yes. I'm from Washington, D.C., and my question is, the information clearly is being disseminated and shared with the IPs throughout. My question is it being shared as much with the NPs that are coming into the facilities that are independent prescribers and are prescribing antibiotics on the without following pausing just because they can bill because they're able to prescribe?
No, yeah, it is a difficult issue, and we know not from the nursing home setting, although we're trying to look at that, but from the outpatient setting, that there is a tendency for advanced practice providers like NPs and assistant physicians. They tend to have slightly higher prescribing rates in terms of antibiotic, and there are several reasons that could drive that. It is an issue, and we are currently doing a lot of focus group testing with this group of providers specifically, and try to identify, what are the causes of this, the drivers of this, and how can we focus our material better and our messaging better to address this provider population specifically. There's a lot of work to be done, and I'm with you. And I'm with you on that. And so in closing, thank you so much for being here today, and thank you so much for your feedback. And you all do the hard work, so thank you.